Welcome to the deep dive. Today we're tackling something that can be, well, really complex. The peripheral nervous system, or PNS.
Absolutely. It's one of those areas where symptoms overlap quite a bit.
Right, like sorting out muscle weakness or weird sensory stuff. If you've been there, you know how tough it can be to figure out where the problem actually is.
hmm Is it the nerve root? Is it one of the big networks, the plexuses? Or is it a specific peripheral nerve further down the line? That's the challenge.
So our mission today is to cut through some of that confusion. We want to give you some solid clinical history points and physical findings to help differentiate these things more quickly.
Exactly. And these PNS issues, they can come from all sorts of things. Trauma, simple compression, sometimes even malignancy or inflammatory conditions.
So to make sense of it all, we've broken it down. We're going to look at three main groups based on how patients might present. First up, wrist drop.
Then we'll tackle foot drop.
And finally, we'll look at those conditions that cause problems in both the arms and legs, the combined deficits.
Okay, sounds like a plan. Let's dive into section 1, wrist drop.
Right, so wrist drop, basically weakness when trying to lift the wrist up, extending it, and maybe some numbness in the hand too. The three big players here are usually radial neuropathy, a C7 radiculopathy, or maybe brachial plexopathy.
Let's start with radial neuropathy. That's probably the most well-known peripheral nerve compression causing this. Think Saturday night palsy.
Ah, yes, the classic. So what history clues should make us think radial nerve?
Usually the patient talks about numbness, tingling, maybe some pain over the back or top of the hand. Sometimes it goes up the back of the forearm or arm.
And the cause.
Often it's pretty clear from the history prolonged pressure, like falling asleep with their arm draped over a chair back. Or it could be direct trauma, maybe a humerus fracture near where the nerve wraps around the bone.
Okay, and this is where knowing exactly where the compression happened becomes key on exam, right? How much does the location change things?
Oh, massively. If the damage is lower down, say at the spiral groove of the humerus, that's the classic spot.
Right.
Then you get that characteristic weakness in extending the wrist and fingers. You'll find sensory loss on the back of the hand, and the brachioradialis reflex might be decreased. But crucially,
What's spared?
the triceps muscle. Elbow extension is strong because the nerve supply to the triceps branches off before the spiral groove.
Got it. So if we do find triceps weakness...
Then you know the problem has to be higher up,
Yeah.
closer to the shoulder, in the axilla.
Okay.
A lesion high in the axilla will cause everything the spiral groove lesion does, plus weakness of elbow extension. The triceps may be sensory loss on the back of the upper arm, and the triceps reflex will likely be down too.
That distinction is really helpful. Finding triceps weakness points you much more proximally.
Exactly. Location, location, location.
All right, so that covers the peripheral nerve, the radial nerve itself.
Yeah.
How does an issue back at the spine, a C7 radiculopathy, kind of mimic this? Because that's a root problem, not a peripheral nerve problem.
Yeah, C7 is a common one, and it gets confusing because the C7 root supplies some of the same muscles. The patient might have neck pain, maybe shooting down the arm, think herniated disc or spinal stenosis.
Okay.
But the sensory pattern can be a giveaway. With C7, the numbness and tingling often localizes specifically to the middle finger.
The middle finger. Okay, that's a key pearl. But what about the motor exam? If the symptoms seem similar, what's the trick to separating C7 root from a peripheral radial nerve injury?
You have to test more than just the extensors. C7 root compression causes weakness in wrist and finger extension, yes, but it also often causes weakness in wrist flexion and elbow extension, the triceps again, because the C7 root contributes to nerves other than just the radial.
Ah, okay. So a pure radial neuropathy down low wouldn't affect wrist flexion, but a C7 root issue could weaken both extensors and flexors?
Precisely. Seeing that pattern of weakness across multiple nerve territories, all pointing back to C7, that's the key.
Excellent, very clear. Now, the third player in wrist drop, brachial plexopathy. This sounds like the whole network is involved.
Yeah, this is generally a bigger, messier picture. You often get patchy weakness and sensory loss kind of scattered throughout the arm.
And pain.
Often, yes.
Yeah.
Severe shoulder or upper arm pain can be a feature. The history here usually points to something significant major trauma, like the shoulder getting yanked away from the head.
Ouch.
Or sometimes it's less obvious, like an apical lung tumor, a Pancoast tumor growing into the plexus, or maybe damage from prior radiation therapy to the chest or axilla.
You mentioned specific trunk injuries within the plexus. What about those, like an upper trunk injury?
Right, the upper trunk involves C5 and C6 nerve roots. Injury there causes Herb Duchenne palsy. That gives you the classic waiter's tip posture.
Describe that again.
The arm hangs down by the side, internally rotated at the shoulder, elbow extended, forearm pronated, and the wrist flexed, like someone awkwardly waiting for a tip. You see this sometimes in newborns after a difficult delivery with shoulder dystocia.
Got it. And if the injury hits the lower part of the plexus?
That's the lower trunk, C8 and T1 roots. That's called Klumpke palsy. This causes weakness primarily in the hand and fingers.
And what kind of things cause that?
Clinically, you associate this often with that Pankos tumor we mentioned, pressing on the lower trunk, or sometimes thoracic outlet syndrome, where things get compressed between the first rib and the clavicle.
It really drives home how important the anatomy is. Compression at the humerus gives one picture. Compression near the first rib gives a completely different one.
You absolutely have to know the anatomy to sort these out.
Okay, let's shift gears. Section 2, foot drop. This is when someone can't lift their foot properly, that dorsiflexion weakness. They might have that steppage gait, lifting the knee high so their toes don't drag.
Exactly. And just like with the wrist, we have a common peripheral nerve issue and a common root issue to differentiate.
So the main players are peroneal neuropathy versus L5 radiculopathy.
Those are the big two, yes. Let's start peripherally again with the peroneal neuropathy.
Okay, this feels like another compression story waiting to happen. If someone has numbness and tingling on the side of the shin, the lateral shin, and the top of the foot, where's the likely spot?
You should immediately think about the head of the fibula. Right there on the outside of the knee, just below the joint. The peroneal nerve runs right over the bone there and is super vulnerable to compression.
And what kind of history points to that?
Common things are habitual leg crossing, maybe someone was immobile for a long time, like during surgery or illness, or even just a tight cast or brace pressing on that spot.
Right. So on exam, if it's just the peroneal nerve compressed there, what specific muscles are weak?
You'll see weakness of ankle dorsiflexion, lifting the foot up, and, importantly, ankle eversion, turning the sole of the foot outwards. Plus, weakness extending the toes.
And the sensory loss matches?
Yep. Lateral shin on the top, the dorsum of the foot. It's usually a pretty neat, localized picture.
Okay, that seems straightforward enough. Now the confusion comes with the L5 radiculopathy. Sensory-wise, it can look similar, right? Numbness on the side of the leg and top of the foot?
It can, yes. But the history often includes that classic low back pain, maybe shooting down the leg sciatica, suggesting a disc herniation, or spinal stenosis pressing on the L5 root.
I remember finding this one tricky. What's the absolute key motor finding that splits L5 root from a peroneal nerve injury?
It's testing ankle inversion.
Inversion, turning the sole of the foot inwards.
Exactly. Peroneal neuropathy weakens dorsiflexion and eversion. But the L5 root also supplies muscles that invert the ankle, which are mainly innervated by the tibial nerve. So an L5 radiculopathy will cause weakness in dorsiflexion, eversion, and inversion.
Ah, so peroneal nerve injury spares inversion.
Correct. Plus, L5 radiculopathy often causes weakness higher up, too. Think hip abduction, maybe hip extension. The root controls a much wider territory than just the peroneal nerve downstream.
That's a critical difference. So test inversion. If inversion is strong, you're likely looking more peripherally at the peroneal nerve.
That's probably the single most high-yield differentiator between the two. Check inversion and hip abduction. If they're normal, think peroneal nerve.
Makes sense. Okay, what about bigger problems affecting the leg, like lumbosacral plexopathy, similar to the brachial plexus in the arm?
Very similar concept, just in the leg. You'll see patchy weakness and sensory loss kind of scattered throughout the leg, suggesting a wider network issue in the pelvis or lower back.
And the history clues here.
Think systemic or major regional causes. Again, diabetes is a big one. Also pelvic malignancy, maybe history of radiation to the pelvis, major trauma, or even prolonged surgery in certain positions, like the lithotomy position.
And is there an emergency sign we need to watch for with plexopathy?
Yes. If the lower part of the lumbosacral plexus is involved, specifically the sacral roots.
S2, S3, S4.
Right. Then the patient might develop bowel or bladder problems, retention, or incontinence. You might also see saddle anesthesia, numbness in the groin, buttocks, perineal area, and maybe decreased rectal tone on exam.
Which leads us straight into the real neurological emergency here. Cauda equina syndrome. That's damage to the bundle of nerve roots at the very end of the spinal canal, right? L2 down to S5.
Exactly. This needs urgent diagnosis and treatment, usually surgery. The symptoms can be unilateral or bilateral leg weakness, sensory loss, often in that saddle distribution we just mentioned, severe low back pain.
And the definitive signs?
Bowel or bladder dysfunction is key. Often urinary retention is the first sign, followed by overflow incontinence. Sexual dysfunction is common too.
And the exam finding you absolutely have to check for?
Decreased rectal tone, along with that saddle anesthesia. These are red flags for cauda equina.
Now let's quickly touch on lower motor neuron signs versus upper motor neuron signs. Cauda equina involves the nerve roots.
So it only causes lower motor neuron signs. Things like flaccid weakness, decreased or absent reflexes, muscle wasting over time.
Okay. But what if you see a mix, like some LMN signs, but also upper motor neuron signs, maybe spasticity, or a positive Babinski sign where the big toe goes up?
Ah, now you're likely looking a bit higher, at the very end of the spinal cord itself. That's conus medullaris syndrome.
How is that different?
Conus syndrome involves injury to the spinal cord tip. It often presents more symmetrically and bilaterally from the start, with prominent and early bowel bladder sexual dysfunction. You might have less severe leg weakness compared to cauda equina, but you can see those UMN signs alongside LMN signs, like absent ankle jerks but present knee jerks, or Babinski.
So subtle but important differences in the pattern and the mix of signs.
Definitely. Location matters.
All right, let's move to our last section, section 3, combined deficits. This is when we see weakness and sensory loss showing up in both the arms and the legs. Suggests something more systemic is going on.
Right. We're usually looking beyond a single nerve or root here. Let's cover 3 main patterns. First, mononeuropathy multiplex.
Okay, multiplex suggests multiple nerves.
Exactly. The key here is that it's asymmetric. The patient develops focal problems, numbness, pain, weakness in one peripheral nerve, say the ulnar nerve in one arm. Then later, maybe the peroneal nerve in the opposite leg gets hit.
So it's like multiple separate peripheral nerve injuries happening over time in different places.
That's the pattern. Patchy, asymmetric, affecting 2 or more named peripheral nerves in different limbs.
And what kind of underlying diseases cause this?
Often systemic conditions that affect small blood vessels supplying the nerves. Think diabetes, certain vasculitis syndromes, HIV, cryoglobulinemia, even sarcoidosis.
Got it. Asymmetric and stepwise. Now, what about the opposite pattern? Something slow and symmetric.
That sounds like chronic polyneuropathy. This is probably what most people think of when they hear neuropathy.
How does it present?
It's typically slowly progressive and very symmetric, affecting both sides equally. It classically starts in the longest nerves, first meaning the feet and hands, and gradually moves up the limbs.
The stocking glove pattern.
Exactly.
Yeah.
Numbness, tingling, burning pain, and weakness starting distally and spreading proximally in that pattern.
And the causes here, are they different?
Often chronic systemic diseases again. Diabetes is the most common cause worldwide. Also, things like B12 deficiency, hypothyroidism, or it could be genetic, like Charcot-Marie-Tooth disease.
And exam findings.
You'll typically find reduced or absent reflexes, especially the ankle jerks first, and that distal pattern of sensory loss and weakness.
Okay, so we have asymmetric stepwise, mononeuropathy multiplex, and slow symmetric distal, chronic polyneuropathy. What about something fast?
Ah, the rapid onset scenario. That brings us to acute inflammatory demyelinating polyradiculoneuropathy. Much easier to say Guillain-Barré syndrome or GBS.
Right, GBS. What's the absolute hallmark of this one?
Speed. It's rapidly progressive weakness. And crucially, it typically ascends.
Ascends, meaning
It usually starts in the legs and moves upwards, sometimes involving the arms, trunk muscles, and even facial and respiratory muscles within days to weeks. The rapid timeline is critical.
and is there often a trigger?
Frequently, yes. Many patients report a preceding infection, often a respiratory illness, or a bout of gastroenteritis. Campylobacter jejuni is a classic trigger, maybe 1 to 4 weeks before the weakness starts. Sometimes it follows vaccination, though that's much rarer.
And on exam for GBS?
You find symmetric bilateral weakness, often quite profound. Reflexes are typically reduced significantly or completely absent early on. And you have to monitor closely for signs of cranial nerve involvement, like facial weakness, difficulty swallowing or eye movement problems, and especially respiratory muscle weakness.
That rapid ascending symmetric pattern with loss of reflexes after an infection that really screams GBS.
It's a pattern you really need to recognize quickly because it requires prompt management.
Okay, so just to quickly recap the big pictures. Wrist drop, think radial nerve, C7 root, or brachial plexus.
Foot drop, think peroneal nerve, L5 root, lumbosacral plexus, or the emergency cauda equina.
And then the combined deficits, mononeuropathy multiplex for that asymmetric patchy pattern, chronic polyneuropathy for the slow symmetric stocking glove, and GBS for the rapid ascending paralysis.
That covers the main categories and key differentiators. It seems fairly neat when you lay it out like that.
Seems neat on paper, maybe. So what's the final thought you want to leave our listeners with thinking about how this plays out in the real world?
Well, the provocative thought is this. While we draw these distinct lines based on anatomy root versus plexus versus nerve, or cauda equina versus conus medullaris, reality is often much messier.
How so?
Think about a large central disc herniation. It might not just neatly compress the L5 root, it could potentially injure the very tip of the spinal cord, the conus medullaris, and multiple nerve roots below it in the cauda equina, all at the same time.
Ah, so you could get a mixture of signs.
Exactly. You could end up with a really confusing, mixed clinical picture. Maybe some UMN signs from the conus injury, alongside classic LMN signs from the cauda equina injury, maybe affecting different levels unevenly. It makes pinpointing the exact location and extent of the injury incredibly challenging initially.
So knowing the pure syndromes is essential, but you have to be ready for these complex overlaps in practice.
Precisely. The real world rarely fits perfectly into textbook diagrams. You need the framework, but also the flexibility to interpret those mixed pictures.
A great reminder of the complexities involved. Thank you for walking us through all of this today.
My pleasure. It's a good discussion.